All right, thank you so much for staying with us on Kakaki, the African Voice, this Tuesday morning. Time for us to go into our very second conversation. And we did tell you that we will talk about the threat by the National Association of Resident Doctors to resume their strike on January 12. And we did have the national president of NARD here on the show yesterday morning. So taking a look at the other side this morning, we have joining us the Honorable Minister of State for Health, Dr. Isiaq Kunle Salako, is here with us in the studio. Good morning, Honorable Minister. Thank you very much for joining us.
It's a pleasure for me to be here.
Thank you for joining us, Honorable Minister. So while we were on break, you had a representative. We had the National Association of Resident Doctors who was on our program yesterday, Monday, and some of the issues that they raised that will make them go on indefinite strike, as we listened, will be salary, non-payment of salaries. He mentioned December salaries, even for house officers who have worked for up to 6 months without pay, and they are unsure when to, receive their salaries. So let me ask you, why do you think that it's appearing difficult for the ministry, that's the federal government, and the National Association of Resident Doctors to come to an agreement to solve this mess?
Thank you very much. First, let me say that government treat the issue of all public servants, take it with all seriousness, including health workers, doctors. And for us, in the Federal Ministry of Health and Social Welfare, maintaining industrial harmony within the health sector, ensuring there is continuity of care is a priority. And so, anytime we approach issues of welfare of health workers, we put a lot of priority around it. For us in the ministry, if doctors, nurses, public laboratory scientists, health workers generally can be paid in millions, we will be very, very happy to have it done. But you know that government has a responsibility, not just to health workers, not just to doctors. We have responsibility to teachers, to the police, to journalists, to the army, and so on and so forth. And so government must do a balancing in terms of the revenue that is available. Of course, we also have responsibility to the entire 240 million Nigerians, creating infrastructures, providing services, and so on and so forth. What I can tell you is that, as an example, to demonstrate the priority attention that government has given to health workers, including doctors, in November last year, government reviewed upward the professional allowances exclusively for health workers alone. And with that review, that has added about almost 90 billion additional commitment of government to their pay on an annual basis. That was done negotiating with all health workers as a team. Now, the issues is that in the past, what used to happen is that doctors will go to government separately to go and negotiate for their welfare, and then government will approve. Nurses will now go after a while to go and negotiate their own, government will approve, and then doctor will now say, what you have approved for nurses has affected our own pay, then they will come back. So there's a vicious circle of negotiation upon negotiation, strike upon strikes. I can give you a typical example. In 2009, some health workers under the banner of Juhesu approached the federal government and got an MOU signed. And that MOU stated that there's going to be parity in the pay of health workers and doctors. I'm sure you know that in the health sector, there are two salary structures. We have CONHES for other health workers, and we have COMES for medical doctors. So Juhesu went and said, and got an agreement for parity. A few years later, doctors also approached the federal government and got an agreement for relativity. These two agreements obviously cannot be implemented together because they are mutually exclusive. You cannot be talking about parity and also be talking about relativity. You know? So we have decided that in negotiating welfare packages for health workers, we're not going to approach doctors different from nurses or from laboratory scientists or from other health workers. Let us jointly discuss it so that everybody is on the table. And you will not say that, okay, that agreement you had, we were not there. We have nothing to say about it. And that is why the process of what is called collective bargaining agreement was started. And as a result of that collective bargaining agreement, we had that increment in allowances for health workers, their call duty, their non-clinical duty allowance, shift duty, rural posting, and so on and so forth, has been increased to up to a tune of almost 90 billion per annum.
So what have you been doing with all of the money and the decisions that you want to see that you treat them maybe equally as they deserve?
No, not necessarily equally.
So why do we still have the fight? Why are they
Now,
threatening
the
to
issue
go
is
strike?
this. When the resident doctors I went on strike last year in November, they had what we call a 19-point demand. And of course, we started discussing it. Today, what they're asking for has been reduced from 19 to 9, which means something must have happened that reduced the demand from 19 to 9. Now, if you now look at some of those specific 9 demands that you're asking for, each and every one of them is being addressed. If you ask me specific questions around those demands, I can address them. For I can give you an example. The issue of specialist allowance, which they are asking for. They, resident doctors, I'm sure you know that resident doctors are specialists in training. They are not yet specialists. They are being trained to become specialists. So one of their requests is that they want to be earning specialist allowance. And of course, that is not a decision for the Ministry of Health, because Ministry of Health does not pay salary of workers. The salaries of workers is paid centrally through the Accountant General's office on the basis of scheme of service that has been approved globally. So we approached the Salaries and National Income Salaries and Wages Commission for advice on whether resident doctors are entitled to specialist allowance. And I have the letter. This is the letter from the Salaries and Wages Commission, where we have been advised that specialist allowance is exclusively for consultants. Because the whole essence of specialist allowance is to encourage people to do specialist training, to become consultants.
Is it possible I flip through? Thank you.
It's to encourage doctors to get trained to become specialists. And don't forget, it is not only doctors that get trained to become specialists. Nurses get trained to become specialists because they are specialist nurses in theater nursing, in nephrology nursing, and so on and so forth. The moment we implement specialist allowance for resident doctors, we as government, it will be a responsibility to us to also implement specialist allowance for other cadres of health workers who are also training to become specialists. So we said no. On the basis of the scheme of service that has been approved, specialist allowance is exclusively for consultants. But they are insisting that they must be paid specialist allowance. That is one specific issue that I've brought out. So there are several other issues like that. For example, their certification when they get trained. They want the National Postgraduate Medical College to issue certificate when they pass Part 1. There are 2 levels of exam. They first do one level that's called Part 1, that when they pass Part 1, the Postgraduate Medical College should issue certification for them. So we wrote to the National Postgraduate Medical College to address it. The Senate of the National Postgraduate Medical College met, which is the authority for approving certification for residents for consultant training in Nigeria. And they came back and said, by their Senate decision is that they do not issue certification for resident doctors who have passed Part 1. The Ministry of Health cannot change that because these are the authorities. And don't forget, this, you cannot as a student go to a school and tell the authorities of that school and that if I pass from primary 1 to primary 2, you must issue certificate to me. Or if I pass from GSS 1 to GSS or SS1, I must be issued a certificate. That must be based on the educational policy of government, which in this case is being superintended by the Senate of the National Postgraduate Medical College, which has met and have decided, these are the trainers, these are the people who train them, these are their teachers. And we said, and they wrote to us that they cannot issue certification for passing part 1. How can you hold us responsible?
So of the 9 demands that are left of the 19 they had as of last year, which of them makes sense to you and which would you be running with? Like the one you're talking about now, the allowances for specialists, which resident doctors are not. I mean, I think it's something you want to negotiate with them, but which of the others 8 now would you say, okay, this is okay, it's reasonable and we can run with this?
No, you see, the truth of the matter is that when we talk about these demands by resident doctors, there's none of them that we are not addressing.
Okay.
There's none of them. I've just cited 2 examples. You know, I have the list of the demands here, and I can start treating them one by one. Let me start from the bottom. Resumption of timely conclusion of the collective bargaining process. The collective bargaining process is an initiative of the Federal Ministry of Health. And they want also, in the first place, NAD, the Association of Resident Doctors, is not in the collective bargaining agreement. It is Nigerian Medical Association.
Okay.
That is in the collective bargaining agreement. Yes, NAD is an affiliate
of NMA.
Of NMA. And we're talking to NMA on how to ensure. Why did we suspend the CBA? 2 critical issues came up in the course of the negotiation. First is the issue of consultant cadre for other categories of health workers. Some other categories of health workers approached the head of service even before we came in, this government, and got approved to be appointed as consultants when they reach some certain level in their profession. And a scheme of service was developed for that. In the course of the collective bargaining agreement, doctors were opposed to that. I also told you, the JOHESU had an agreement on parity. Doctors had an agreement on relativity. 2 mutually exclusive issues. So until we resolve those 2 issues, the collective bargaining agreement could not move forward. So we said, okay, let us sit back and find a way to resolve those 2 issues. And to resolve the issue of relativity and parity, we said, let us get the National Salaries, Income and Wages Commission to do what we call a job evaluation. A job evaluation will be to now look at, because we're not just paying for certificates, we are actually paying for the job you do.
The competencies.
The competence, the kind of skills that you bring to bear at work. So we said, okay, Salaries and Wages Commission, let us do a job evaluation. And the Salaries and Wages Commission has said that it's going to take them about 6 months to do that. So we said, pending the time the job evaluation is concluded, where we can use that, the outcome of that job evaluation to resolve the issue of relativity and parity, we will move for the increment in the professional allowances of health workers, not just doctors, because our responsibility is not just to doctors, it's to all health workers. So, like I said, we have been able to use that mechanism, and government has approved, this government has approved an increment in the professional allowances of all health workers. So that is one area. On the issue of consultant cadre, we said that, look, what is important is not the name, it's the job description that you are going to do. If you are appointed a consultant nurse, for example, what is your job description? What are you going to be doing? That is what is most important, rather than the terminology or the term that you are called. So we said, okay, even you doctors, come forward with suggestions on what you believe should be the job description for each categories of this. Of course, there's a scheme of service for each of these categories, but in order to also carry the health workers, everybody along, said also, you should also come forward with submissions that can help us to properly define, because the concern really, which we appreciate as ministry, is that we do not want a situation where a consultant nurse, for example, now is doing the job of a consultant physician, or believes that when a consultant physician does this, he can do otherwise or something like that. So we must create a situation where there is harmony, because this is a team service.
And proper delineation of duties.
Proper delineation of duties. So that is what is holding back the CBA. So that's about the CBA. But as of yesterday, the Minister of Labour has informed me that because the CBA is actually not our prerogative in the ministry, it is a prerogative of the Ministry of Labour. They chair it. The Minister of Labour has informed me that they're going to restart the CBA process as soon as possible. Commencements of locum and work hours regulation committees. This we agreed with them because they came forward that, look, there is a, because of the frequency at which doctors and health workers generally are leaving the service, government has given the window for management of hospitals to be able to take people on temporary basis to fill vacancies when they occur. Because to employ people on permanent basis, there's a process within the service. You have to get head of service establishment approval. You have to get budgetary approval, you know, and so on and so forth. You have to get federal character approval. So we now said, okay, to serve as a stopgap, people can be employed on locum basis pending the time that approvals are gotten for permanent approvals. So we have set up a committee to develop a uniform guideline for the engagement, because prior to now, there was no uniform guideline. Each hospital was just doing it based on the way they look at it. So we're now developing a uniform guideline to do that.
Okay.
Recategorization, I've addressed that, of membership certificates and issuance of certificates.
Honorable Minister, if we keep looking at each of these items, there are, how many did you call it? 19?
Nine.
9 of
From
them.
19 to
From
9.
19 down to 9 now.
Yes.
But one key thing that has stood out for me as you described it is that all of these negotiations seem to involve a whole lot of stakeholders from within government circles and even in the medical sector too. Will that account for why it looks like government is slow to react or to act on these demands by these workers? Because one of the critical things that Dr. Mohammed Suleiman talked about yesterday, the president of the of NAD, talked about was that government has not done the needful in a number of cases. He talked about the need to just write letters, for instance, to reinstate the 5 doctors who were disengaged in Lokoja.
Okay, let me address the issue of those 5 doctors. Those 5 doctors falls into 3 categories. 2 of them, in one of them, as far back as 2024, faced the senior staff. You know, there's a process in the civil service for discipline. And ordinarily, process of discipline does not get to political office holders in the civil service. As a minister, I really don't have a role to play. There's a public service rule. There's a guideline issued by the head of service to discipline public servants when they err. So, as far back as October 2024, one of them faced the Senior Staff Disciplinary Committee. And the Senior Staff Disciplinary Committee recommended that that staff employment should be terminated, which was passed through the normal civil service process, approved, and his employment was terminated. Another one also faced, I think, sometimes last year, his own employment too was terminated. There are 2 of the other ones, that is category 1. 2 of them that they faced the Senior Staff Disciplinary Committee that had their employment terminated based on the procedure in the civil service. 2 of them also faced, another 2 faced the disciplinary committee, and the disciplinary committee recommended that they should be reprimanded. Another one, which is category 3, was unavoidably absent because of illness when the disciplinary committee was meeting, so she could not meet the disciplinary committee. So when they now made it...
So what happened to her?
When they now made it a strike issue, that is what brought us as political office holder into it. Because ordinarily, like I said, it shouldn't come to us. So now we said, okay, what do we do? They've written an appeal. Each of individual concerned wrote an appeal to the ministry to intervene. NAD also wrote an appeal. And then we now set up a committee, a 3-man committee, which I inaugurated, to please look at it and see how we can address the appeal in line with the civil service rules. And the committee came back with their recommendations. Now, the ministry reviewed the recommendation and has agreed with made some decisions, which we have communicated or we are communicating to the parties concerned. One, on the person who could not face the disciplinary committee, said she should be invited to face the disciplinary committee, because there must be fair hearing. The committee that we set up recommended that she should be reprimanded. And we felt that she has not faced the disciplinary committee because reprimand is a punishment in the civil service. You cannot punish somebody who has not got fair hearing. So we said, no, let her go and face the disciplinary committee. When the report of this, because the disciplinary committee may just even say she's been discharged and acquitted, she has no case to answer.
So, and she would have been reprimanded.
And then she would have been reprimanded. So we said, okay, let her go and go. The other two that we said, the disciplinary committee recommended that they should be reprimanded. The committee that we also set up to review also said they should be reprimanded. So we said, okay, go ahead, reprimand them, let them write a letter to be of good conduct. And then they can continue their work. The last two, whose appointments were terminated, we said we reinstate them. But because of ensuring there's order in the service, rather than reinstating them in Lokoja, where they face the disciplinary committee, they are free to apply to any other federal hospital of their choice, and they will be reinstated in those hospitals. That's the decision we have taken around those 5.
So, Honorable Minister, when the president of NAD appeared on Kakaki yesterday, he said, when you agitate, you are taking off work. So he begs to differ that maybe they were even found guilty of anything. So when you were answering now, you said it's not within your purview as the Minister of State for Health who stays or who leaves the civil service, solely the activity of the head of service. But when you say we recommended or we brought them back, who is the pronoun of that we?
No, when we're talking about we now, you know that, like I said, it is because this issue has become a strike issue. When it becomes a strike issue, you know, you cannot...
It comes to your office.
Yeah, you cannot leave it totally to civil service system alone. You know, because it has now become, it has been nationalized, it has been brought in as an industrial dispute issue. You know, so in doing that, the management of the ministry sit over it, which include the minister, the permanent secretary, the directors in human resources, director in legal, director in hospital services. And the review of the recommendation is now jointly done. And then a decision is taken that can be seen at the decision of the ministry in this case. This also still has to be transmitted, of course, to the head of service, who is #1 civil servant. So that is the situation with respect to that.
Okay, so, but for members of the public, especially those who are watching right now, I'm sure they're wondering that we keep seeing recurring strikes, especially in the health sector. The former producer of this program, Shola Ebola, fell ill and was taken to the Federal Medical Center here in Abuja. And of course, when I visited, I noticed that it was just the doctors and nurses that were on duty. Every test that was done, the family had to go and do outside of the hospital. And for members of the public, this may be a bit disconcerting because it increases the stress that the caregivers go through and all of that. A wife of a colleague fell ill and nearly died because she was a caregiver. So what is the ministry doing? What new approach is the ministry taking now to ensure that strikes we don't even get to the point of strikes? Because from all you have described, because of the number of agencies of government, ministries, departments and agencies that are involved in all of this, the Ministry of Labor, the FMOH, the Head of Service, the National Salaries, Incomes and Wages Commission and all of that, the wheels of government grind slowly. So How can we fast track all of this
You know
so
that-
that
let me say
we
this.
don't get to this point where the health sector seems to be grinding to a halt?
Well, first, it is unfortunate that to experience strikes, because what we want is no strikes. But I must let you know that globally, strikes within the health sector has been on the upward string. As an example, between 2023 and December last year, there has been 14 strikes in the United Kingdom alone of resident doctors. 14 between 2023 and December last year. As I'm speaking, in France, some categories of strike of doctors
But there
are
are
on
good
strike.
parts that we can always copy.
No,
Why
no,
does
no,
it seem
because
like
I'm laying a foundation.
we like the part that is not
Don't
working?
just talk about, because Nigeria is not outside the global community. What is the reason for the strikes that is on the upward string? That's what I'm trying to get to. First, there is a global shortage of health workers. So, health workers that are working generally are overstretched globally. There's a global burnout. That's number one. Number two, the global economic downturn has also affected the ability of government to be able to meet the welfare need of health workers. In the UK, for example, which I also cite an example, there has been an erosion of the pay of health workers by about 20% over the last 20 years or thereabouts. So, but in Nigeria, if you contextualize it, one of the key reasons why we have recurrent strike in the health sector is government has been negotiating not collectively with health workers in the past. And this time around, we have decided that we're not going to be negotiating individually, we're going to be negotiating collectively so that everybody is on the table. It doesn't mean that you are going to 100% agree. But when you're on the table, you bring forward your own, I bring forward my own. And that's why, for example, the increment in allowances that I spoke about. When it was first introduced in August last year, some health workers protested against it and said they were going on strike. But I said, we withdrew it immediately. And we now called everybody until everybody agreed.
All right, Honorable Minister, we have to run because we have a segment, a package before we call it a day on Kakaki, the African Voice, on Tuesdays. But as you leave us, what's your word to the National Association of Resident Doctors as they insist that if nothing happens January 12th, they go on strike?
Well, for us, we will just continue to appeal to them. I spoke to the Minister of Labour yesterday, who is the Chief Conciliator of industrial disputes. And he has assured me to also take some actions to engage the resident doctors, or also call the ministry to be on board. We will just continue to appeal to them and to all them appreciate that each of these demands that they have made, there's nothing like ministry has not written letters. It is not correct. Each of those items are being addressed in accordance. But you see, sometimes, like you said, if you don't follow due process, the end point will be worse than what you are trying to prevent. So we have no other way other than to ensure that due process is followed, to ensure the implementation of whatever agreement that we have entered into with the doctor. So we continue to appeal to them.
All right, it's a good place to leave it this morning. Thank you very much, Honorable Minister. We've been speaking with the Minister of State for Health, Dr. Isiaq Kunle Salako, looking at the issues that were raised on this program yesterday by the President of the National Association of Resident Doctors, all in a bid to ensure that there is industrial harmony and that the health sector doesn't get grounded. Thank you very much, Honorable Minister, for coming on the program this morning.
Thank you.
Thank you.
All right, we'll take a break now and bring you Global Agenda.